Next, we'll have my co-moderator, Professor Ashraf Omar. So Professor Omar is a long-time AASLD member, but in addition, he's Professor of Hepatology and Tropical Medicine in the Faculty of Medicine at Cairo University and President of the Egyptian Society of Liver Cancer. And he'll be speaking to us about treatment of early-stage disease. Professor Omar.
Thank you very much, Professor Lewis, for inviting me to join the AASLD session, and I would like to extend my deep thank to Dr. Manel and the whole team of COLDA, the wonderful team of COLDA, and everything is perfect. Thank you very much. When we are talking about treatment of HCC, the early HCC, we have to have some rapid data, epidemiological data, that HCC is the fourth most common cancer in Africa, with differences in the prevalence and etiology between North Africa and Sub-Saharan Africa. In the Sub-Saharan Africa, HCC is the second leading cause of cancer-related deaths from men and the fourth for women. And the age standardized mortality rates is 8.2 and 4.2 per 100,000 persons per day, per year, respectively. HCC presents in a younger age, as mentioned by Dr. Nicole, at the area of high incidence, and the median survival is from 3 to 4 months. In 2020, Sub-Saharan Africa had the fourth highest number of the diagnosed HCC cases worldwide, with more than 38,000 new cases of HCC. What about Egypt and other countries in Africa? Egypt comes the second worldwide with a very high rate, more than 28,000 cases per year, and the age standardized is more than 34. Again, other countries in Africa, like in Guinea, 28.8, Gambia and Ghana, like 17 AASLD. So there is a problem of HCC in Africa. And when we look to the staging workup of the hepatocellular carcinoma, we have 5 stages according not only the burden of HCC, but the most important is the general condition of the patient, the performance status, as well as the liver status. So we have 5 stages, and of course, the most important management of liver cancer should be in a multidisciplinary way, MDT, for the better results, and respecting the tumor stage, the liver status, and the performance status as well. So this is the updated Barcelona staging workup, and we can see that we have 5 different stages, and today we are going to talk about, in this presentation, the early stage management. And the early stage management is having 2 subgroups, the very early and early stage, and part of the intermediate stage as well, as we are going to mention. For the early stage, we have the concept of cure. We have a very early stage, single tumor, at least 2 centimeters and less than 5 centimeters, or the early stage is up to 3 tumors, but less than 3 centimeters, and of course with no macrovascular invasion or extrahepatic metastasis, and preserved liver function status. These stages, 2 stages, are eligible for cure, and the cure response is evaluated by the overall survival and the recurrence rate. And when we look to the very early stage, which is the BCLC O or 0, the ablation, we have, as you see, ablation, resection, or liver transplantation. The ablation is the preferred option, then resection should be considered first. As a second option, recently added for the first time 2 other options, which is transarterial chemoembolization and transarterial radioembolization, which is considered, and in a way of a staging migration study, strategy, which has been recently introduced in the updated Barcelona 2022. The TER is considered as effective as TACE, but it is recommended only in a single HCC and after the legacy trial. And the wonderful legacy trial is on just a single tumor less than 8 centimeter. Performance status is okay, no extrahepatic metastasis. And this important legacy study showed a good results regards the tumor, overall survival, progression-free survival, and all the data showed a significant improvement. And according to this study, for the first time, TER has been introduced in the guidelines as a second-line treatment in early stage treatment, not in the late stage treatment. For the next subgroup of the early stage, which is BSLC-A, which is multiple lesions, less than 3 lesions, and each one is less than 3 centimeter. Resection is favored, and also liver transplantation if multiple, with no distant metastasis, with no vascular invasion. And if the patient is not candidate for liver transplantation, so we can move for ablation by TACE or TER as second-line treatment, as mentioned. BCLC-B, according to the recent version of the it is an intermediate stage. However, it shows 3 subgroups. The first subgroup may be a candidate for cure. Patients candidate for cure. We have 2 other subgroups. The second group, which is multiple lesion, but the portal vein is patent, and it may be candidate for TACE therapy. And the third group is multiple infiltrative vascular invasion, and in that such subgroup, third group, is the systemic therapy is the only treatment. However, what about the first subgroup? The first subgroup, candidate for liver transplantation if they meet the extended liver transplant criteria, after which is candidate for potential cure after downstaging, and we can go for liver transplantation. So we have, according to the treatment option, we have liver transplantation with an overall survival, the best overall survival, more than 70%, 5 years, with the recurrence rates from 6 to 15. Surgical resection, which is the second overall survival from 50 to 70, 5 years, and the recurrence rate is more than 60% of the patients at 5 years. And percutaneous ablation, the overall survival is comparable to the surgical resection, with local recurrence rate from 3 to 22% at 5 years survival. All 3 therapies are considered potential curative treatment for the early HCC management. And recently, as mentioned, added the transarterial chemoembolization and TER as a staging migration treatment strategy. And here is the data of the different options of the treatment according to the better, the best, and the best, and so on. So the best data or the best treatment outcome is from the transplantation, then resection, then ablation, then TACE less than 5 centimeter, ablation less or equal 5 centimeter, and TACE and TER less or equal to 5 centimeter. We are respecting Milan criteria, as it has several options, which is remove the cirrhotic liver, which is predisposed to tumor formation, and eliminate the capacity of the post-resection liver and adequate liver volume. And if we are respecting Milan criteria, we are going to have a better overall survival, 5-year survival, maybe over 70%. And if we are not respecting the Milan criteria, it is over the overall survival, like in up to 7 criteria, and so on. So if waiting time exceeds 6 months, it is better recommended to consider treatment by bridging or whatever, as I'm going to mention. And recently, in the updated guidelines, the alpha-fetoprotein, if exceeding 1,000, it is absolute contraindication for liver transplantation. However, after any kind of downstaging, if the alpha-fetoprotein is getting down below 500 nanogram per ml, so we can have an outcome comparable to those reported for patients within Milan criteria. So the downstaging is a good strategy to fit inside Milan criteria, either by radiofrequency microwave TACE or even surgical resection, and there is no form over the other in the results. And this is some Egyptian series of liver transplant outcome after liver transplantation. It's cited from Professor Dr. Amr, and this series showed that the outcome, the overall survival, first 3 years and 5 years survival, and Milan versus the extended Milan are very much comparable, as well as the recurrence-free survival. Of course, Milan is much better. However, this data showed an important point, which is that after the efficient downstaging therapy, the downstaging therapy has rendered the USSF or an extended Milan criteria and the up to 7 criteria more usable than before to be included for liver transplant. So we can use this downstaging strategy to increase the possibility of liver transplantation, which is a kind of cure for the patient, not an ablation. So we are aiming the cure of the patient. For the surgical resection, treatment of choice with tumors smaller than 5 centimeters in the absence of cirrhosis, of course, only 15 to 30% due to the degree of underlying cirrhosis. 75% of the patient will develop intrahepatic recurrence within 5 years due to de novo or local recurrence. And of course, so far there is no portal hypertension, so we can get the best results over the liver resection. And this is an important data, systemic review of the outcome after hepatic resection in comparing non-cirrhotic HCC versus cirrhotic HCC. And of course, the median overall survival in the non-cirrhotic is much better, 55 versus 46. And the disease-free survival also is better in the non-cirrhotic. It's 48.8 versus 26.9. And the poor prognosis, of course, is due to the multicenteric de novo carcinogenesis. There is a kind of a scoring system, which is a multi-parametric assessment, including the portal hypertension, the extent of the resection and the liver status. And respecting these data, we might predict hepatic decompensation after liver resection. So we have a high, intermediate, or low risk for liver resection. Ablation is an important one for the early treatment of HCC. Microwave radiofrequency placed percutaneously offer overall survival comparable to the resection, potentially curative modality for patients who are not candidate for resection, and can also considered in downstaging for liver transplantation in the intermediate or advanced stage of HCC. And these are the needles of the microwave versus the radiofrequency, and the microwave is having a potential over the radiofrequency in some points, like the rapid way, the consequences, the complications, and so on. So microwave is a better choice, and we can use it just adjacent to a major blood vessel versus the radiofrequency. For TACE and TER, both are accepted now as a second-line therapies for the early stage of HCC, and according to the stage migration policy, it is, of course, contraindicated in extrahepatic diseases and so on. And TACE versus TARE. TARE is selective and super selective for HCC, is having a very high complete response rate. TARE, a small prospective study of selective TACE in early HCC for BCLC 0 or A demonstrated a 3-year survival of 80%. There is no head-to-head study TACE versus TARE. However, TARE is indicated for single lesions less than 8 centimeter, where TACE is recommended for multifocal disease. And it is contraindicated to choosing one over the other. However, a small randomized study demonstrated that TARE lead to significantly increased time to progression versus TACE. And there is a merit liver transplant trial in the downstaging showed both together, both versus TACE versus TARE has no differences in the rate of or time for successful downstaging. Patients with prior biliary instrumentation are at high risk for hepatic abscess after TACE, and the ischemic effect of the TARE is minimal compared to TACE. Finally, there is a combo therapy, ablation plus embolization, and recently there is a randomized controlled trial of large number of patients demonstrated that the superiority of overall survival for radiofrequency plus TACE compared with radiofrequency alone for early HCC less than 7 centimeter. And now systemic therapy may be now used in early stage, yes, as an adjuvant after ablation or resection to decrease or to prevent recurrence after cure, like in Pembro, Mono, or Nivo Nono, or Atezolizumab, and so on. These are an ongoing clinical trial, and we are just waiting for the final results. And in conclusion, the treatment of early HCC has improved the outcome with transplant, resection, and ablation, and the recently added TACE and TARE in the stage migration treatment vision as a new modality for early HCC list for curative options may soon join. And finally, I would like to show this important figure, which has been published in the Lancet Gastroenterology a few years ago, showing the bad outcome of survival of HCC among African countries and in Egypt. This is why, because the very late presentation of the HCC, so we need urgently to have a screening program for early detection and awareness program for health education, hepatitis elimination program in view of the WHO call 2030, and the need also for African guidelines for HCC. And from this context, we are working, Professor Dr. Lewis, Professor Dr. Abu Alfa, and me and the other expert in the field in different countries of Africa, working now to finish the African guidelines before the end of this year. Thank you very much.